Welcome, bienvenue, willkommen. I'm Professor John Kirton. I'm the director of the G8 Research Group and co-director of the G20 Research Group, the BRICS Research Group, and the Global Health Diplomacy Program at the University of Toronto in Canada. And it's my great pleasure to serve as your chair for this important event. A session where we take a close look at the G7 and the G20 and ask what have they done for global health, what can they do, what should they do. There's good reason to believe that when the most powerful leaders of the world's most powerful countries gather together regularly at these summits to combine the unique authority, legitimacy, and flexibility that they alone have, that good things can be done for global health. But it's not always the case that potential is put into practice. So how it can be, how it has been, is what we're looking at here. You'll recall that the group of 8 major democratic powers was co-founded by German Chancellor Helmut Schmidt in 1975. Its latest annual summit took place under the chair of Chancellor Merkel at Schloss Elmau down in Bavaria at the beginning of June. And next year it goes to Japan to the Shima Summit in late May. The G20 group of systemically significant states, the G8 plus the major emerging countries, held its first meeting here in Berlin at the ministerial level in December 1999. It's holding its next summit, its 10th anniversary one, in Turkey in Antalya in a few weeks' time in mid-November. Next year it's on to China, and then the year after that, everyone expects it's coming to Germany again. So there's good reasons right here, right now, to take a close look at these two Gs and their performance in global health. And to do that, we've assembled a distinguished array of speakers, experts, contributors from many of the critical sectors involved in global health governance. Civil society, the private sector, the government, the intergovernmental community, and the academic community as well. I'll introduce each of them specifically when I invite them in turn to give their 15-minute opening remarks. And we begin with Joe Cerrell, who is the director of the European Office and the managing director for global policy and advocacy from the Gates Foundation. There's only been one occasion at a G20 summit in which one individual has been asked to sit in with the leaders for a session, participate as an equal. That was here in Europe in 2011. The individual selected was Bill Gates. So we're particularly delighted, Joe, that you're here to lead us off.
Good afternoon. Thank you very much for that introduction. It's a pleasure to be here at the World Health Summit, speaking to an audience of people who, like me, spend most of their time thinking about global health, why it's so important, and what we can do to improve it. To maximize our impact, though, it's vital for us to focus and to convey our message to the broadest possible audience, to the leaders that make decisions about funding, and to the voting public to whom these leaders are accountable. The recent UN General Assembly has given us great hope and given us one of the best advocacy opportunities possible. With the ratification of the Sustainable Development Goals last week, the UN has made a very strong statement that the future depends on global health. The task now is to make sure that the world does everything in its power over the next 15 years to meet the global goals, which is why I'm speaking on the role of the G7 and G20 in helping people lead healthy and productive lives. Like the UN, the G7 and the G20 are for where world leaders articulate top priorities and take action. When member countries commit resources to specific global health priorities, they are taking a lead role in not just envisioning, but also building a better future. We are seeing this right now with Germany's exemplary leadership of the G7. Reacting to the Ebola crisis at the end of last year, Chancellor Merkel used the power of the G7 to insist that our world is prepared for future epidemics. The G7 also agreed this year to prioritize investments in neglected tropical diseases, diseases that don't get much attention in most places, but take a terrible toll. If this year's summit is any indication of what the G7 can do to advance global health in the coming years, and if the G20 can make global health a key part of its agenda as it continues to evolve, then the world stands a good chance of meeting not just the health goals, but all the goals related to health, from ending poverty to promoting gender equality. When I joined the Gates Foundation in the year 2001, it was a brand new organization. We spent a lot of time working with another brand new organization, the Global Fund, to fight AIDS, TB, and malaria, which was created at the G7 meeting in Italy that same year. We were excited about the Global Fund back then, but I don't think we had any idea how successful an organization it was going to be. Let me describe that massive difference that organizations, including the Global Fund, have made. AIDS is increasingly a disease people live with rather than die from. And the rate of new HIV infections has fallen by more than 40%. 85% of new tuberculosis cases are detected and receive long-term treatment. Malaria deaths have been cut by 60%. Just a few weeks ago, Nature magazine reported that in the past 15 years, 700 million cases of malaria have been prevented. These are stunning results, especially if you recall what it was like back in 2001, before the Global Fund started doing its work. According to Newsweek's second cover of the new millennium, AIDS was cutting through Africa like a malevolent scythe. The UN wrote that it was the most devastating disease humankind has ever faced. So I'm particularly pleased here to be sharing the stage with Norbert Hauser, the chair of the Global Fund, who will talk more about the fund's progress. Now, no one's declaring victory over AIDS, TB, and malaria, and the future in large part depends on whether donors in the G7, G20, and elsewhere meet the fundraising targets at the upcoming Global Fund replenishment. But now there is hope, where once there was mostly hopelessness. The Global Fund is just one example of the G7's leadership in global health. In 2010, under the presidency of Canada, the G7 launched the Muskoka Initiative to accelerate progress on maternal and child health. And that story is just as positive as the one on AIDS, TB, and malaria. In the past 15 years, the lives of 48 million children under the age of 5 have been saved. That's more than the entire population of Spain. The even better news is that progress is speeding up, not slowing down. The world is saving children at twice the rate we were a generation ago. So the Muskoka Initiative's goal of accelerating progress has been met. Looking at the G20, it is a younger forum, created after the 1999 financial crisis to promote financial stability, but one with a significant potential to address the health challenges of countries that make up its membership. These countries have an impressive experience in health. One reason for that is that they understand the economic value in investing in it, as demonstrated recently by the Commission on Investing in Health report, which showed that the benefits of investing in basic care are 10 times greater than the costs. The lessons G20 countries have learned by addressing their own health challenges can form the basis of the G20's engagement over the long term. Take India, for example, which has cut child mortality by 60% since 1990 and eliminated polio within its borders. Or South Africa, which has performed what many experts call a miracle in controlling its AIDS epidemic. It has more people on treatment than any other country in the world. The transition of HIV from mother to child is down 90%, and life expectancy has increased by 10 years since the height of the crisis. These countries not only know how to improve health, they also know why improving health is such a priority for growth and stability. The expertise these countries gained by engineering these successes now sits with the G20, which is poised to become the leader in the same way the G7 has been. So history shows that investments in health work, and that organizations like the G7 and G20 are key to galvanizing the boldest of these investments. History will have to repeat itself over the next 15 years, however, if we hope to achieve the Sustainable Development Goals. I believe that there are a few priorities on which the G7 can lead in the future. The first is to continue to support the work of the Global Fund. As I mentioned, Germany is going to play an active role, we hope, in the replenishment in 2016, and we look to Germany and other G7 nations to increase their investment in one of the most successful global health programs ever created. The second priority is research and development. The Gates Foundation CEO, Sue Desmond-Hellmann, was here in Berlin just a few days ago, giving a speech on this very topic, making a strong case for greater investments in R&D, particularly into poverty-related diseases. She said the G7 can help by increasing their support of innovative public-private partnerships, including product development partnerships, or PDPs. As many of you know, these are not-for-profit organizations that use private sector management practices and partners from all sectors to develop new products for global health. This approach has already shown substantial promise. Today, our foundation funds 15 of these PDPs that have launched more than 30 new products in the last decade, including breakthroughs such as a new meningitis vaccine, a new test for drug-resistant TB, and a new malaria drug for children. There is also an opportunity for the G7 to support and strengthen surveillance to help developing countries detect outbreaks before they happen. Our foundation is supporting the development of the Child Health and Mortality Prevention Surveillance, or CHAMPS. This network will establish 6 sites in Africa and South Asia to collect comprehensive, standardized primary data addressing all causes of death in children under the age of 5. The ambition is that the CHAMPS network will grow to more than 20 sites over the next 2 decades, an ambition that would benefit from G7 and G20 engagement. The third priority is investing in primary health care. This work may not seem as exciting as rolling back AIDS, TB, or malaria. It's about routine things like prenatal visits, vaccination, and proper nutrition. But these routine things prevent people from getting sick in the first place and give them the chance to live up to their full potential. As part of this effort, we need to build on the role that women can play as primary caregivers. By delivering basic care and information to women, usually with frontline health workers who are also women, you can reach everyone. We're used to thinking about women's health and primary health care as separate issues. They are inextricably linked, and the G7 can help make those connections. Finally, I'd like to elaborate on the role of the G20 going forward. It is, yes, still a young forum with the potential to join the G7 as a leading player in global health, but increasingly the G20 can and should provide resources for global health priority in the same way the G7 does. As Bill Gates wrote in his report on health and development to the G20 several years ago, one of the newest resources for development, and potentially one of the most transformative, is rapidly growing countries' capacity for innovation. We are excited to see the G20 tap into its capacity for innovation in the next 15 years, particularly in global health. G20 members are well positioned to provide their knowledge and expertise to other developing countries. Take China, for example. China has been investing in African health and agriculture. Over the past 2 years, the Gates Foundation has been partnering with the Ethiopian government and the China-Africa Development Fund to support the Jinyu Group, a Chinese animal manufacturer of vaccines, to set up a manufacturing plant in Ethiopia. It will produce high-quality vaccines for foot and mouth disease, a widely prevalent disease among the cattle population in Ethiopia and its neighbors. The investment contributes to better animal disease control, improving the overall livestock sector, including its export potential. More recently, during President Xi's recent trip to the United States last month, Centers for Disease Control from China and the U.S. announced their collaboration to support the establishment of the African CDC. Both countries played a prominent role in the Ebola crisis, and their CDCs have a lot to offer to strengthen the soon-to-be-established Africa CDC. There is significant potential for further engagement. These are strong examples of positive collaboration between G20 countries and demonstrates the potential of the G20. There is enormous payoff in investing in health. According to the Commission on Investing in Health, or the CIH, reduction in mortality account for 11% of recent economic growth in low-income and middle-income countries as measured in their national income accounts. With the right investments and changes in policy, by 2035, every country will have child mortality rates that are as low in the US or in the UK in 1980. And if we reach that goal, every dollar invested in health will have brought economic return of $9 to $20, according to the CIH. These returns on investment in health are impressive, and the potential for greater returns are more impressive, and more impressive outcomes are possible only if we strengthen our commitment and bring others on board. I started the speech by saying we in the global health community need to find ways to make our case to the rest of the world, and by saying that the G7 and G20 are two good ways of doing that. I want to conclude by speaking directly to the people in this audience, those of you, my colleagues, to the people who don't sit at the table at the G7 and G20 summits, but who work tirelessly on these issues. Everything I've been talking about starts with you. And one example of that is the Global Fund. That never would have happened without your advocacy, your policy, your research and development of new products, as well as your expertise in service delivery. We need partners, but we also need to keep pushing ourselves. We need to ask the hard questions, and we need to answer them with innovation, passion, and patience. The stronger our evidence, the more powerful our arguments, the more creative our ideas, the more we are ensuring that the G7 and G20 will continue to help people live healthy lives around the world. Thank you very much.
Thank you very much, Joe. Our next speaker is Hiroki Nakatani from Japan. Hiroki currently serves as the advisor for international affairs to the Minister of Health, Labor, and Welfare in the Japanese government, but he's simultaneously a professor at Keio University, one of Japan's most distinguished, and brings to bear his experience for several years from 2007 to 2015 as an Assistant Director General at the World Health Organization. And I've also informally appointed him to take all our good ideas about what the Shima Summit should do back to his leader. So, Hiroki.
Thank you. Good morning. Good morning. That is what I can say in German. But, our chair, colleagues, and ladies and gentlemen, it is my pleasure to be here to present a hybrid view of mine regarding the reminiscence and perspective of the Japanese presidency of G7. Why hybrid? As Chair said, I am one of Health Minister's advisor, and which requires me to speak very rigidly, and it is not fun. So I think I will wear sometimes a cap of a university professor, where active debate is a norm. Today, I wish to combine both of my backgrounds and offer you a panoramic view of the Japanese commitments in health at the forum of G7, G8. Japan is proud to host the G7 summit meeting next year, and the main venue is Mie Prefecture, Ise-Shima, which is located 350 kilometers west from Tokyo. And Health Ministers meeting in September, which locates 60 kilometers from my hometown, Kyoto. First, let me review the past Japanese experience as G7 or G8 presidency. Japan has hosted 5 times in the past, particularly at the 2 recent summits. We pushed forward a new health agenda. At the Kyushu-Okinawa summit in 2000, leaders discussed communicable disease. At the time, HIV-affected individuals in the North started to benefit from treatment. But the majority of HIV persons in the South had very little or almost no access to treatment. This situation was not acceptable and also was a negative factor for development in many countries. The leaders discussed and led to concrete actions. As a consequence, a bold decision to create the Global Fund to fight against AIDS, TB, and malaria was agreed in the following summit hosted by Italy. The Global Fund and other concerted efforts, together with the works of affected countries, became the engine to promote the health development goals, particularly MDG 6. Japan was and is proud of this achievement, which proves our belief of the goodwill and strength of international solidarity. Since then, we have been seeing massive investment in health, starting from MDG 6 areas, followed by MDG 4 and MDG 5. While we must congratulate on our progress, at the same time, many lives still continue to be lost due to diseases that we know how to prevent and how to care. Enough reason to support Global Fund to continue. The second concrete outcome of Japan-hosted summit was the re-emphasis of health systems. The reason was, while the disease control efforts were making progress, the vertical approaches had reached their maximum effectiveness and efficiency. For example, healthcare workers tend to move to priority disease control programs that was funded by donors. This eroded national systems and efforts. Also, disease control programs could be better supported by well-functioning health systems, but the investment of health systems was far from sufficient. Increased attention was given to the allocation of international resources to health systems. Japan has a long history of health development. That is why we are convinced to do so. That comes from Hokkaido summit in 2008. But one might ask why Japan is taking such initiatives. At other summits, Japan engaged very actively in health debates, and I wish to refer to an example later. But the legitimacy, that is the legitimate question, is why Japan health is matter. In my view, it is because of our commitment to human security. The concept of human security is to liberate people in all nations from misery, war, conflict, poverty, and ill health. The concept was first delineated after the end of the Cold War, where human misery was supposed to move from war to poverty and ill health. Japan firmly believes the value of this concept and has strived to contribute to regional development as a good and peaceful neighbor. This position will never change, and that is why health matters. Health is a central issue in human security. This is the essence of Prime Minister Abe's debut article in Lancet, September 2013, entitled Japan's Strategy for Global Health Diplomacy, Why It Matters. Ladies and gentlemen, I said that Japan has been active in summits, and now I wish to refer to a prime minister from my alumni, Keio University, Mr. Ryutaro Hashimoto. He was a minister for health when I entered the ministry as a junior medical officer some times ago. I didn't disclose because I disclosed my age. The minister and also ministry had a bureau to help war veterans and recover the remains of soldiers in Asia and Pacific Islands are one of our work. Mr. Hashimoto himself visited remote areas and saw malaria and filariasis among the locals, particularly the poorest among the poor. This convinced him to raise this parasitic disease in the forum of G7 meeting at Birmingham. He raised a concern about parasitic disease, which later turned to be a very good program of neglected tropical disease in WHO. And here in Berlin, experts meet in 2004 and identify 70 priority NTD diseases to tackle. This program is grown to be very unique private-public partnership involving UN agencies, involving pharma industries. So that is very interesting development. Consequently, now we are moving to eradicate drunken chlorosis, if I can pronounce rightly. That is guinea worm disease. And we are close to eliminate as public health problem leprosy, lymphatic filariasis, African sleeping sickness, and blind trachoma. So we are moving forward. But next year's summit, it will be very much interesting because it's the first full summit after adoption of SDG. And we all know the power of international agreed goals and targets. And MDG worked very well. But on the other hand, if you look at SDGs, as you see that there is some, and MDGs, health MDGs 4, 5, 6 are central of our 8 targets. But now, 8 goals, but now health-related goals is one of 17. And very specific targets is concerned. Under MDG, about 40% of targets were health-related, but now under SDG, only 15. While health sector, within the health sector, more diffuse agenda may mean less progress in addressing challenges that MDGs prioritized, and the new targets are less quantitative, and in other words, more aspirational. There is reason for health sector to worry about. And Dr. Mark Diable spoke in this forum yesterday that this question mark is frightening. So that is the sense of health sector. Then what Japanese are going to do? The agenda setting process of G7G8 is very delicate. Japan will listen to other members carefully before finalizing the issue to be discussed. Some candidate issues, that is what I'm going to talk about for discussion, are likely based on Prime Minister Abe's official position, which was voiced in a variety of forums. So let's walk through this. In his first article, as I mentioned earlier, in Lancet, Japan's Strategy for Global Health Diplomacy, Why It Matters, Prime Minister stressed his firm commitment to health MDGs and emphasized the need of expanding universal health coverage. His view is that such effort will allow Japan to contribute to international communities, and this will form soft power in global politics. He expanded such idea further and spoke at UN Sustainable Development Summit on 27 September this year, where he emphasized his will to expand the health systems to respond to public health emergencies and achieve universal health coverage. In September 2015, Government of Japan, the Ministry of Foreign Affairs, developed the health development policy entitled Basic Design for Peace and Health, reflecting his position. And the Ministry of Health also launched the Japan Vision Healthcare 2035, in which domestic and international health agenda are in harmony. This is some basic design for peace and health. So 3 components. public health emergency, universal coverage, and health systems are interrelated. And this is partially illustrated by this summary figure. First, our response to public health crisis and natural disasters. We learned hard lessons from Ebola. Previous session of today's panel look at this issue. International response needed time and to be coordinated. And during that time, infection spread and costed more than 10,000 lives. We need better international support system capable of promptly responding to emergency. But the emergency should not be limited to acute infection. Natural disasters require similar response. And we learned from many lessons, including ours. Also, we need to strengthen fundamental response to infectious disease as a backbone of acute response, as well as response to emerging microbial resistance, including multi-drug resistant tuberculosis. This will also contribute to complete our work of MDGs by ending epidemics of 3 major infections. The point is that all such effort must not be fragmented and must not be ad hoc, but must be harmonized and coordinated, avoiding duplication of agencies and inefficient use of resources. This is where governance issue is coming. Second, universal coverage. It is obvious that we are now matured enough to graduate from project-based approach to more comprehensive and lifelong approach to disease control, when non-communicable disease have become the predominant cause of ill health. Various health concerns are well accommodated. As Prime Minister Abe mentioned in his UN speech, strengthening health system is essential to better prepare international community against public health emergencies. We had lots of debates on health systems, and we cannot continue just debates. We need action. Finally, we feel our experience in the last 50 years are very relevant, since we are the front runner of super-aging society, where already over 25% of population is over 65 years old, but still most of them are very active and productive. Our innovation in medical products and technology, as well as experience positive and unexpected side effects, will be useful. We are committed in international collaboration. So this is a kind of figures of global health governance issue. So we often look at the peak of iceberg, but there is under the sea there is many components to address, like global health financing, how we are going to fix about or to activate international health regulations, how research and development is promoted. So few of these issues, or not few, many of the issues was discussed already at the panel of antimicrobial bioresistance in this forum. UHC. Now let's turn to UHC. The picture is Gupta's map published in the New England Journal in September 2015, which illustrates countries undertaking or not undertaking universal health coverage policy. Japan is proud of its universal coverage of health insurance, which has been an engine to promote longevity at a relatively mild pace of cost increase. However, due to rapid aging of population and decline of working population, we need good preparation for sustainability beyond 2025, when the baby boomers reach 75 years old, beyond which demand for medical and welfare services would surge. We have experience to share, and we are determined to meet the challenge of making our super-aging society happy and sustainable. Since many countries in the world are following this path, this would be one of the priority issues to discuss at the G7 Health Minister Summit meeting in Kobe next year. Also, universal health coverage are interrelated with many aspects of health, gender equity, insurance, access to medicine, measurement, just to mention a few. Aging. One of the challenges of sustainability of health insurance, a very important component of universal health coverage, is aging for us. Aging deserves special attention at the Summit Health Ministers meeting, as I said. Indeed, aging offers both challenges and opportunities. And now, super-aging society, which Japan is facing, and needs fundamental change in many aspects of society. For example, last week, KO co-hosted a meeting with the World Economic Forum, where we discussed the response of the financial sector. In Japan, rapid aging population includes a group of persons with cognitive decline who have problems managing their assets. Minister Shiozaki came to our meeting and made opening remarks, end quote. As the first aging society, Japan is ready to contribute to overcome the healthcare challenges of aging society. Japan is fully committed to contribute not only our society but also global health. As the chair of G7, Japan continues to tackle the global aging issue. One day, I visited my bank and I saw a gentleman who could not withdraw his money from ATM machine because he forgot his PIN number. After trying a few times, the cash card was blocked. And then he started to get agitated. This is a daily phenomenon in Japan. To safeguard the interests of senior citizens and to offer steady opportunity for investment are challenging in banking and other business, but at the same time offer business opportunities. To facilitate such process, many changes in society, rules, regulation, and business practice are necessary to be changed. KO received education grant from the Ministry of Education and has started intersectorial studies and education program to meet such challenges. Therefore, I personally would like to see aging to be a part of the agenda. Then Japan vision of 2035 is illustrated here. What our health minister, that is a group of submitted report to health minister, would like to see that international health and domestic health are separate issues. That is interrelated and integrated issue. That is the point. Ladies and gentlemen, as I said earlier, the agenda will be shaped by close consultation with other G7 members. It will also be important to be sharp against the real issues behind the agenda. For example, personally, I would like to see active debates on a couple of questions. For example, how related agencies, WHO, World Bank, UN agencies, and NGO work together in collaborative manner. How, in reality, health security and universal health coverage can be supported by strengthening the health system. What lessons we learn to use MDG or health disease control efforts to strengthen health system. All these are coming to mind, but we need to have a good discussion about this. The issue raised are ambitious. Health systems, governance, universal health coverage, and aging. Each topic deserves a lot of thoughts and dialogue with stakeholders. We have set up opportunities within the next 12 months, starting from the universal health coverage meeting and global fund replenishment meeting in Tokyo in December. These will eventually lead us to the summit in May in Isushima and health ministers meeting in September. I must stress that shaping the health agenda is a consultative process with G7 members, and this process is just begun. So I must insist that what I have discussed today is not yet fixed. Japan is committed to global health, and I wish to emphasize that our value, stems from our desire for peace and health, the value of which we have honored in the past 70 years. Thank you very much.
ありがとうございます。Our next speaker is Norbert Hauser, who comes to us from the Global Fund to fight AIDS, TB, and malaria. He's currently chair of the board, but he also brings to us the vital experience of having been a legislator as a member of Parliament and an auditor and an inspector general as well. The Global Fund, I should note, has the unique distinction of being the signature achievement of at least two G7 summits, Okinawa 2000, but also Genoa 2001, and some might even add Elmau, where the leaders promised that next year there would be a successful replenishment, right? So I'm hoping you'll tell us how many dollars or euros you need so we can measure success.
Thank you very much. I might be able to tell you how much you can save, but I can't tell you now how much we need at the moment, but we'll get near that. Ladies and gentlemen, thank you very much for this invitation, and thank you for the opportunity to share with you some thoughts about the exciting opportunities for our joint efforts in the coming years. As chair of the Global Fund Board, may I have my slides, please? Okay, great. Thank you. I'm particularly honored to present here a success story of a G8 political commitment taken in 2000 in Okinawa, as you Hiroki already mentioned, and resulting in an innovative model that has mobilized and disbursed more than $27 billion to tackle the epidemics of HIV, AIDS, tuberculosis, and malaria. Back in 2000, the three diseases appeared as impossible to control, and 15 years later, we can formulate the goal to eliminate them as epidemics. In countries where the Global Fund invests, and I think one can't repeat these figures often enough, we have seen a 40% decline in death caused by AIDS, 29% decline in death from TB, and 48% decline in death caused by malaria. It was at the G8 summit in Okinawa in 2000, hosted by the government of Japan, that infectious diseases were first elevated to the highest level of political attention. At the following G8 summit, 2001 in Genoa, hosted by the government of Italy, the first pledges were made to a new organization that was still in the planning phase. A few months later, in January 2002, the Global Fund to fight AIDS, tuberculosis, and malaria was created and started its operations. The Global Fund mobilizes and invests nearly $4 billion every year to support countries and communities most in need. Ever since 2000, the Global Fund, its mission and the results achieved have been regularly on the agenda of the G7, the G8 summits, and been part of their accountability reports. Saving 17 million lives in the last decade is a significant achievement in the public health domain, and the Global Fund has done it through its partnerships with its donors. One of the most important is Bill and Melinda Gates Foundation. Thank you very much, Joe. Technical agencies, implementer country governments, and large networks of affected communities and civil society organizations. 8.1 million people are currently on antiretroviral treatment with support from the Global Fund partnership. Since 2002, Global Fund support has financed treatment for 13.2 million people and distributed 448 million bed nets for malaria prevention. Many, many more lives can be saved in the years to come by enlarging the partnerships even further in the cross-cutting spirit of the SDGs, by using new tools to have been made available through scientific research in the past decade, and by applying innovative financing mechanisms and ensuring that domestic resources are invested in the most impactful way. To fast-track the end of the AIDS epidemic by 2030, low-income countries will require $9.7 billion US, domestic financing about 10%, in funding in 2020, and lower middle-income countries, 8.7 billion, domestic financing about 22%. Due to their income status and the scale of their HIV epidemics, these countries will continue to need international support to fund their AIDS response. While the costs may be high in the short term, every dollar spent controlling HIV infections will yield 15 times the benefit in the long run. These initial investments will help to avert 24 billion of additional costs for HIV treatment. I'm pleased that the World Summit has put a strong focus on antimicrobial resistance. Of the 700,000 estimated deaths each year from AMR, nearly one-third, or 210,000, are caused by drug-resistant tuberculosis, which has the distinction of being both a leading cause of death from AMR and an airborne disease that can be easily transmitted across borders. For the first time ever, governments have set a goal to end the TB epidemic by 2035. As you can see from the slide, if the current trend in incidence reduction continues, it will take about 180 years to end the TB. That is to say, we really need to bend the curve and invest much more aggressively in this area. Not isolating TB as a separate problem, but rather tackling it within the agenda of AMR could help us to achieve more. We are proud of our achievements in reducing malaria significantly. The malaria report published by the World Health Organization and UNICEF in September this year stated that malaria death rates have plunged by 60% since 2000. The report shows that malaria MDG target to have halted and begun to reserve the incidence of malaria by 2015 has met convincingly, with new malaria cases dropping by 32% in 15 years. This is a truly historical achievement and very promising for many countries that are now moving from malaria control into pre-elimination. Yet, we need to keep vigilant and maintain targeted investments to ensure that achievements are not lost through a resurgence of malaria, especially in the context of climate change. Organizations such as the Global Fund are making a significant contribution towards the SDG goal number 3, focusing on health to ensure healthy lives and promote well-being for all at all ages. The Global Fund partners with countries to enable them to provide necessary health services to their populations. The Global Fund is conscious of the fact that its role can only be complementary to the efforts of the countries themselves, and that most of the resources will have to come from domestic source of finance. Since 2014, the Global Fund has worked with implementing countries to mobilize additional $5.7 billion in domestic resources for health for the period 2015 to 2017. Compared with the spending the area from 2012 to 2014, this represents a 52% increase in domestic financing for health. We will work to expand this further. We need broader political support from all partners and G7G20 leadership to continue mobilizing domestic resources. Global Fund's investments in the three diseases have achieved the emergency response that had to be delivered in order to bend the curve of the epidemics, but these targeted investments have also had important spillover effects, moving towards resilient and sustainable systems for health in our partner countries. Strengthening of procurement and supply chains, quality of programmatic data, community mobilization toward improving the access to health care for marginalized populations. Yet, much more significant efforts need to be invested if we want to see the health systems be resilient to disease outbreaks such as Ebola. On a global level, the market leverage of the Global Fund has contributed to achieve greatly reducing inequalities in accessing treatments for the three diseases. It has achieved affordable medication in developing countries. Much more remains to be done to reduce the inequalities in accessing treatments against other diseases. The strategy of the Fund for the next 5 years is articulated around the scale-up of evidence-based interventions for the highest burden countries with the lowest economic capacity and for key and vulnerable populations. Make an important contribution towards building resilient and sustainable systems for health. Promotion of human rights and gender equality. And in order to reach these objectives, we want to mobilize increased financial resources and also encourage the development of technological innovations and fair pricing for medicines. A holistic view, as implied by the SDG, means we must not see health as an isolated area of interventions. Education, gender equality, poverty reduction, these are all factors that have tremendous impact on progress with regard to HIV, TB, and malaria. And vice versa, health initiatives can make an important contribution to realize the SDGs in other areas. Investing in health is good for business and economy, as healthy people can work and contribute to the wealth of their countries. Global Fund's experience shows that political commitment to health is absolutely critical in mobilizing resources, ensuring efficient use of resources, reducing waste and corruption in the health sector, bringing communities in as partners in rendering patient-centered care, and achieving affordable prices for drugs that will provide the necessary treatments without ruining the country's health budgets. Over the last 15 years, the G7G8 has regularly put health and development high on the political agenda and thereby contributed to the enormous achievement in global health. The G20 has traditionally focused more on economic issues and crisis management, explicitly not accepting development as being part of their mandate. In a rapidly changing world, it would be desirable that all political leaders reiterate their political commitment to the SDGs in concrete terms and play a crucial role in placing health high on every government's agenda so that all countries can raise their domestic investments in health to sufficient levels and strengthen the national public health capacity. All sectors of economy have to participate in finding solutions to render their populations healthier. All actors involved in healthcare have to come together and complement each other in achieving viable solutions. Health is vital for every one of us. Thank you for your attention.
Our next speaker, bringing a private sector perspective, is Mitchell Morris from Deloitte. Mitchell is a vice chair there and leads the global healthcare sector. There he covers the sector as a whole, but also has some sense of the broader economic and financial system in which health is integrally embedded. So Mitchell, we're looking forward to your remarks.
Good morning, and I'm delighted to be here today. I think the last speaker gave a good setup for me because hearing about the remarkable progress that's made in communicable diseases really helps understand some of the challenges we're going to be facing in years to come, because many of these populations will survive those illnesses only to be afflicted by the same things many of us in this room talk about more often for ourselves, like being overweight, diabetes, tobacco-related diseases, cardiovascular, cancer, etc. And I do believe that the G7 and the G20 should consider a role in looking at non-communicable diseases, and especially the role of stimulating innovation and looking at structure, because there are many structural challenges we have today, and it's highlighted by one of the things that we do at Deloitte. Of the many services we provide, we help plan and stand up hospitals, so a maternity hospital in Botswana, a cancer hospital in China, a children's hospital in Mexico. And I'm struck by the fact that as we plan for health systems in countries with underdeveloped or emerging economies, they often aspire to be more like Western medicine. And if I could have my first slide, one has to wonder at the wisdom of that and some of the structural challenges we have. And I think you're familiar with some of this data, the remarkable amount of money that is spent in many of the member countries, and of course led by the United States with over $9,000 per capita. And it's really striking that in India it's under $100 per capita, in China it's under $400 per capita. But those governments are actively planning for and hoping to be spending more and looking more like the kind of systems that we have in the U.S. And of course, even though U.S. is number one in spending, we are dead last in health outcomes. This is a conglomeration of measures made by the Commonwealth Fund and shows a variety of issues around quality of care, access to care, efficiency, and equity. And the U.S. doesn't perform so well despite spending all of that money. But I would say to you that a number of other countries on this list have similar problems. And we continue to be faced by costs continuing to rise. So as we talk about the cost of HIV and anti-malarial medications, the cost of medications to manage cardiovascular diseases and cancers continues to grow. And I even used an example on this panel of a communicable disease, hepatitis C, where in the United States a course of treatment is $84,000, and if everyone in the United States were to get this treatment, it would double our total pharmaceutical spend. So looking at the models of care and the structure of care for all diseases seems quite important, because the United States Americans live shorter lives. It does not have to do with, than these other countries. It does not have to do with income in the United States, because if you look at white, insured, college-educated, upper-income Americans, they do more poorly in health outcomes compared to their peer countries in Europe. So some of the challenges that are faced really globally, and I'm fortunate that I get a chance to visit with many countries in different states of development, are the costs of medical advancements, especially with drugs. We're going to continue to see that increase over the next few years. There's so many exciting new developments that are wonderful to hear about for the potential of saving lives. How we can afford them is difficult to say. We're seeing, despite universal health coverage in that nice map we saw earlier, many countries are starting to implement two-tier systems. The private market forces are going in that direction, where American-style health plans, which are not necessarily desirable, and private health care is operating in parallel to a country-based system. Fragmentation is remarkable. So on that panel from the Commonwealth Fund, UK is number one in care coordination, but in the UK there's really no linkages between primary care and acute care. So if they want to take care of people across the continuum, it becomes very difficult. And if I look at developing nations, fragmentation is quite rampant. And looking holistically at a citizen, at a consumer, I don't want to call them patient, because you're not a patient until you're sick. It's hard to look at the whole picture of individuals. The social determinants of health care are getting better understood, but we do very little to address them or do something in a meaningful way. We have a lot of evidence in the medical literature as to the best way to care for different ailments, yet we are very slow to implement evidence-based practice across the board. And in most countries, we structure health care around the doctor, and I'll say this because I am a doctor, but we should be putting it around the person, around the consumer, not around the doctor. So those are some of the challenges we face. And as we look to influencing policy and influencing structures in countries where they're starting with something that looks a little bit more like a blank slate, there's a chance. So I'll use a metaphor from manufacturing. And many years ago in manufacturing, when the assembly line was first introduced, people talked about, well, the assembly line's broken, everyone take a break, and we're going to call the repairmen, they're going to fix it. So that's a break-fix approach. And that's the way most medicine is today. It's very reactive. In the United States, we have wonderful break-fix medicine. If I need a new heart valve, I know exactly where to go. They'll do a great job. But in terms of helping me stay healthy, maybe not as much. So we moved in manufacturing to preventive maintenance. I think that part is probably going to break down after 4,000 hours, so I'm going to replace it at 3,500 hours. And we have some approaches towards preventive maintenance in healthcare that are reasonably good, yet not all the way there. And where manufacturing has gone for some time now is predictive maintenance, continuously monitoring systems and understanding when there are problems and making adjustments, making improvements along the way. And ideally, that's how people would be taken care of as well. And this is the same principle shown here graphically. As we get to a optimized predictive model of healthcare as opposed to break-fix healthcare, we have an opportunity to lower cost, improve productivity by every measure, improve quality by every measure. And again, manufacturing has been there for a number of years. Part of some of the change is defragmentation of the healthcare ecosystem, the separation of primary care, specialty care, and acute care, and providing those things as individual interactions is not optimal, particularly for the chronic diseases that the aging are privileged to get. So some of the things that we are looking at, and it is a conversation not only happening in the G7 and the G20 nations, but also in those emerging economies that want to maybe leapfrog the bricks and mortar phase of building very, very expensive hospitals and infrastructure, and how to prevent people from getting in there in the first place, is looking at some of the illnesses on this list. Compliance is a big issue in pretty much every country. In the United States, the Deloitte Center for Health Solutions does an annual survey of consumer attitudes towards healthcare. One of the questions we ask is, if your doctor writes you a prescription, how likely are you to get it filled? The answer is 50-50. And if you get it filled, how likely are you to take it the way the doctor told you to take it? The answer is again 50-50. So 1 in 4 Americans are taking their medications the way their doctor said they should take it. And there are many reasons for that. Some of them are economic, some of them are cultural or fear or denial and all kinds of things. But for some of the things on this list, if you take your medications and have reasonable dietary and activity compliance, you will probably stay out of the hospital. You may even stay out of the doctor's office. If you don't take your medications, you will get sicker and have all the sequelae that go along with these medical conditions. So as we start to look at countries that, like Mexico and Brazil and China, there is a tremendous interest in figuring out how do we align incentives so that it makes sense to improve compliance, improve awareness, look at some of the social determinants of health and wellness in the first place, which impacts dietary activity, compliance, and taking medications and so forth. There's technology enablements today that link these environments together. So for an asthmatic who can sit at home and as a child and blow into a spirometer and over their cell phone measure their ability to move air, have that information centrally collected, and if there's a problem, have someone call them on their cell phone and ask them how they're feeling, talk to a parent. Maybe they should stay home from school. Maybe they need to take some rescue inhaler. But they may not need to get so bad before they have to actually come into the hospital and be seriously ill. The ability today to wire the home or the work or the school setting is pretty remarkable, and monitoring so we can keep people healthy is something that we've really advanced in. So putting those things together, the ability to coordinate care and to engage with people. We know that many developing nations, cell phones predated having wired systems and a lot of the infrastructure. The ability to reach out and understand health by communicating directly with the people in the environment and those kinds of enabling technologies, including electronic patient records and automation systems. We have the content. We know how to take care of many of these non-communicable illnesses, as well as those that are infectious, and the ability to use analytics and understand how do we get the most bang for our buck. I don't think there are many countries, including the United States, that want to spend $9,000 per capita on health care and still have a problem. We should be able to spend far less and do far more with that. So we have the content, we have the technology, we have some of the analytics, and what are lacking are financial alignment, because today in the UK there is no financial reason for a trust to work with primary care, for a hospital system to work with the primary care doctors. They know it's the right thing to do, but the structure, the financial structure, doesn't exist. So even in countries with universal health coverage and government health coverage have challenges. And that also comes in with a policy alignment. So how can policymakers begin to incentivize systems that put things together so people do not get sick and we're not stuck in the world of break-fix medicine, but instead are doing predictive maintenance? So there are a number of successful examples out there where innovation is being stimulated by the government. A notable one is in the United States, where the Centers for Medicare and Medicaid Services has a variety of programs. Some of them go under the headline of accountable care organizations to align payment mechanisms with people working together in the provider world. So physicians, hospitals, nurses, physical therapists, psychologists, because mental health is an important part of it as well, working together to maintain the health of a population. The early results are, yes, some savings are there, and good satisfaction among consumers is there. Another example is in Spain, the Alzira model that's been started since they started devolution in 2002, has used an approach to population health with remarkable improvement in outcomes and decrease in hospital utilization. The United Kingdom is starting a program of devolution, and Manchester is the one that's spoken about most. And I think what's really innovative and unique about that one is not just about health, it's also about social care. Health and social care, how do we wrap that up together? If you believe what you read in the newspaper, it's £6 billion a year, sterling, as they say. And how do we make sure that we spend that in an intelligent manner to drive good health and do so with a different model of care than the break-fix mechanism. And the last example I'll use is in Australia, where they put together the Primary Health Network, which again is a model of accountable care. These problems are not unique to the G7 or G20 nations, and I think there is a role as non-communicable diseases increase in incidence and prevalence and awareness in these other countries. How do we not repeat building the structure, financial structures and bricks and mortar of break-fix medicine, and instead help stimulate policies that take us in another direction? Thank you.
Thank you very much. Our final presenter is Michael Myers, who comes to us from the legendary Rockefeller Foundation, which has been doing global health longer than I think almost anyone else. Michael heads the global health work there and is focusing on two of the biggest, toughest health system strengthening as a whole and universal health care coverage. So we're particularly eager to hear what you have to say.
Thank you, John, and it's great to be here with everyone today. I will talk about, a number of the speakers have talked about things that the G7 and G20 can do right away, currently, and those are important. I will focus a bit on what they might do into the future. But let me start, as John indicated, we at the Rockefeller Foundation work heavily in building up and strengthening health systems with the goal of achieving universal health coverage. And we believe that is important because it's an equity principle, that if we're going to build up health systems, we need to reach everyone. So it is with that introduction that I mentioned that we're really proud that many others are now joining the space of building up health systems. Important work has been going on disease-specific conditions. That's extremely important, but we have to have the health systems to go with it. So the recent commitments by Germany on building up health systems, Japan's commitment to health system strengthening, as well as universal health coverage, the Gates announcement on primary care, I think adds a lot of energy to that space and a really promising future when it comes to building up health systems. I need to pause for just a moment to celebrate what has happened on universal health coverage in recent times, however. And there was a great session yesterday on that particular topic. We have seen, if you imagine back just 5 years ago, if someone in this hall had said, the world will unite around achieving universal health coverage, that speaker might have been laughed off the stage. It was just a pipe dream at that particular moment. But in 2010, we saw the WHO release a landmark report on universal health coverage as an effective way to move forward. In 2012, we saw the UN General Assembly pass a resolution calling on countries to set as a goal universal health coverage. In 2014, civil society celebrated the first Universal Health Coverage Day, UHC Day, which will continue every December going forward. In 2015, that we saw the first global monitoring report on USHC that was released just earlier this year in June, bringing us a step closer to accountability and measurability of achieving universal health coverage. Just last month, Larry Summers and other economists came together on a statement that investment in health systems and universal health coverage is good for economies. So one after the other, the arguments against universal health coverage, the skeptics have been put aside by each of these arguments, and now today we have more than 100 countries that have made commitments toward universal health coverage. So I think that's something we can all celebrate. So contained within the SDGs, there is the target on universal health coverage. I just love this statement. It's the encapsulation of so much work by so many people that to promote physical health and well-being and to extend life expectancy for all, we must achieve universal health coverage. These words are in the preamble, and access to quality health care. No one must be left behind. So that is a global commitment on the part of so many nations, and it's terribly exciting to see that moving forward. Now, looking to the future, we have 17 Sustainable Development Goals. How can we possibly embrace all of that as a global community? So let me propose some ideas for how we in health bring all of this together, and a number of speakers have spoken to this as well. We must continue our focus on health system strengthening, health system building, health governance, universal health coverage. That work is important, it's immediate, and it must go on. But I think these goals present us in the health sector with a unique opportunity to do what we should be doing anyway, which is working across sectors. That's the way the world works today. That's the way the solutions of tomorrow are going to come. So we can see within these goals that health is a clear connector among the SDGs, inextricably intertwined with water, food, diversity, climate. And for the sake of human health, we must extend our vision and widen our lens. We must recognize that our health and the health of our planet are linked. Now, recently, we all got very excited when the U.S. Space Agency, NASA, started talking about the possibility that there is liquid water on Mars. And here's a planet 225 million kilometers away, and we were all fixated on the delicate balance of the water and the environment on Mars and the possibility of life. It was fascinating to us. We need to have that same kind of fixation here on our own planet, on Earth, going forward. Look what's happening. We see a rapidly changing climate, and this has resulted in higher temperatures, fewer forests, less diversity of living species, water shortages, and the list goes on and on and on. So, simply put, the biggest threat to human health is the degradation of our planet. Air pollution. It's taking its toll. The WHO estimates that more than 7 million people each year die from air pollution-related conditions. 7 million people die prematurely due to indoor and outdoor air pollution. There was a study just last month published in the journal Nature about outdoor pollution and its effect on human health. And it concluded that the death rate due to air pollution, outdoor air pollution, is higher today than that for malaria and HIV/AIDS combined. And that will double by 2050 if nothing is done. Extreme events, climate-related, harsher storms, more droughts. This is our future as humanity on this planet. As a result to the changes in the planet, these are more extreme, and I don't need to go into the details of the health consequences of floods and storms and droughts and more. Those are obvious ones. Less obvious, the quantity and the quality of our food. The quantity of our food will be is affected by land degradation, soil erosion, loss of pollinators, overfishing, ocean acidification, water scarcity. And the quality of our food will be affected as well. The nutritional content of the basic staples that many of us rely on, rice, wheat, legumes, will decline, will change as a result of rising carbon dioxide as well as rising temperatures. So the food that we rely on today will no longer bring the nutritional benefits that we've come to be accustomed to. So, for example, zinc content, iron, protein. WHO estimates that as much as a third of the world's population already suffers from zinc deficiencies, and these affect brain functions, they depress immunity, which leads to other diseases, and they pose a range of other health problems. And again, this will only grow. We have also an evolving disease landscape. I think Margaret Chan mentioned on Sunday about the changing disease vectors as a result to changes on our planet. This is the reality that we're facing going forward. And this is where new thinking and a new field, I believe, comes into play. A field that we are calling at the Rockefeller Foundation planetary health. So, what is planetary health? Planetary health is an emerging discipline that embraces the links between the health of human civilization and the natural systems on which our lives depend. There was recently completed work by a Rockefeller Lancet Commission on planetary health, and I encourage you to look at their findings. They were issued in the Lancet in June or July of this year, and really amazing findings about the science behind a lot of the thinking that needs to go on regarding the health of people, the health of the planet, and how those are related. Sir Andrew Haynes, who's one of the speakers this afternoon, was the chair of that commission, and I encourage you to listen to what he has to say. It's really a stunning conclusion about what needs to be done going forward. And we at the Rockefeller Foundation have invested a considerable amount of time and resources in developing, doing the early groundwork for this field. But we've done this before. Field building like this, new thinking like this, is nothing new to all of us. We at Rockefeller were involved 100 years ago now in helping to build up the field of public health. At the time, we were seeking to end hookworm, particularly in the southern United States, but also elsewhere. This particular photo was in Thailand when we were working there on eradicating, trying to lower the incidence of hookworm. But what we found at that time is relevant to this discussion today, which is we needed at that time to bring together not only the medical knowledge of that time, but sociologists, educators, people involved in policy and government, bringing that all together. And what emerged was not just a combination or a cooperation between those fields, but the new field of public health, a new way of thinking, a new set of solutions going forward. And that's what we need for this, our time, is to build this field of planetary health. So to achieve the SDGs, we need a new model that aligns people and planet. And it's time for us to build a new public health that meets the challenges of this century. It's time to build what I'm calling public health 2.0, or what many call planetary health. This is the way to unify our work and on the SDGs, and possibly a path forward for the G20, for the G7, and all of us assembled here today. Thank you very much.
Thank you very much. As at G7 and G20 summits themselves, so at sessions such as this about them, there's always too little time. We're lucky in that we have available for our question period the lunch where you can buttonhole the individual speakers, ask your questions of them bilaterally, give them your best idea. But just before we collectively break, let me ask what I think Margaret Chen identified as the key question, implementation. We know that summit leaders and countries in the G7, G8 comply with their health commitments at a level of about 75%. Solid B, which is pretty good, unless, of course, you're part of the 25% on the other side of the line. So how do we improve implementation, and how can our respective sectors, civil society, business, academy, governments, intergovernmental organizations help? Joe, do you want to lead off quickly?
Yeah, sure. I do think it's important. And I think that over the years, we've seen built-in accountability systems become more part of the strategy, meaning making sure that the commitments first are documented and that there is ample time spent on understanding exactly what leaders are signing up to. And it can be a kind of laborious debate back and forth to try to understand. If we talk about, for instance, agriculture commitments, that we know what is it that we're signing up to. And I think it absolutely highlights the role that civil society can and should be playing, and I think has a pretty good record over the years of playing, to make sure that there is a way in successive years to really track whether commitments are being made, and if not, use that as the basis to really push leaders and push through the G7 Sherpa process to make sure that those commitments are actually met. The other thing I would say, too, is I've seen increase, and this is very encouraging, I think, in the trend. You see increased continuity amongst the G7 summits. So I think there's encouragingly a handoff, I hope, that Germany will make to Japan in ensuring that some of what Germany really took active leadership on will be built upon in Japan in the future. There will be, I think, a process that makes sure that some of the issues that were raised do, in fact, have a through line to the next summit.
Hiroki?
Yes, it's very good answer. So I have very little to add. But I think continuity is important. For example, I think German's health ministers meeting highlight was antimicrobial resistance and also Ebola. That can be easily accommodated with health security agenda of Japan is going to take. And also, I think UK summit in the past, it was highlighted by dementia. That is aging issue can accommodate. So all this, I think, continuity is important, and also monitoring, particularly from academia and civil society, is very important. Thank you.
Norbert?
Thank you, John. Just talking about health, I think we have to make clear we're not talking about funding. We're talking about investing. And as soon as we know about the costs of inactions, it's much easier to get governments taking over their responsibility. As far as the communities are concerned, the communities are absolutely paramount. Paramount not only to reach the last mile for the treatment, to reach out to the people in need, but as well to assure resilient health systems. When we are transitioning, and we hope we can do that one day, that the countries can take over and develop their country ownership more and more, like, for instance, South Africa with about 80% on HIV already in domestic financing, then we still need the communities and the civil society to monitor and track what the governments do. And without this monitoring and tracking, we won't have resilient and sustainable health systems. So therefore, health system strengthening, yes, but don't forget the communities and the civil society.
Mitchell.
I think those comments are well stated, and I would add to that coupling economic development with health development and investments and engagement of the private sector, because it is an investment and the private sector is going to want to see a return on that investment. There's a case to be made, but sometimes I don't think we make the case as vocally and clearly as we can do to get those extra parties to the table to help with economic development in these countries.
I think we all have the same answer. It's quite remarkable about the role of particularly of civil society, because if the World Health Organization sets measures and targets for accountability, they cannot criticize governments that miss the targets. So there needs to be something independent doing that, and that's civil society. One thing we've been instrumental in organizing at the Rockefeller Foundation is a coalition of more than 600 civil society organizations in more than 100 countries around the world, and they're committed to holding their governments accountable for progress on that going forward.
Okay, thank you very much. With that, it's time to move from talk to walk to lunch to the bilateral question and answers. But before that, let me on your behalf thank our speakers for very comprehensive, insightful remarks, and I look forward to gathering together a year from now when the Shima Summit will be under the gun. Thank you very much.